In this lecture, I will be talking about the concept of inflammation, more specifically the exemplars of hepatitis and pancreatitis. The liver produces bile, which aids the body in breaking down and absorbing fat. Bile is stored in the gallbladder and is released into the small intestines when needed. The liver also handles and processes nutrients that are carried out from the small intestines via blood. Inflammation of the liver, known as hepatitis, impedes the processes or functions of the liver. Hepatitis is a prevalent condition throughout the world that generally results from an underlying infectious agent or virus. It may also result from autoimmune disorders, alcohol or drug abuse or misuse, and exposure to industrial chemicals. Different types of viral hepatitis. There's type A, B, C, D, and E. We're mostly going to concentrate on A, B, and C, but you should know that D and E exist. They do have similar clinical manifestations, but they have some of them have different modes of transmission and the disease course itself. Less common, it's associated with viruses such as CMV, Epstein-Barr virus, herpes, Coxsackie, and rubella. Like I had stated previously, there are different modes of transmission for each one of the hepatitis, the viral hepatitis. So Hep A is it is transmitted by a fecal oral route. So this is usually the result of people who are handling food and they are not washing their hands after going to the bathroom. We've seen in the past that there has been some restaurants that had like a Hep A outbreak, mainly because the people didn't wash their hands that were uh, cooking or making the foods. The one that kind of comes to mind is Hamburger Mary's that was down in Ybor City. They had a couple of other restaurants in like Brandon, and I think there was one over in St. Pete as well. They ended up having a Hep A outbreak, and it causes people not to want to go to the restaurants anymore. So a lot of times the restaurants end up closing up. Hep B is from contaminated needles and syringes and blood products. It can also be from perinatal or unprotected sexual activity. Hep C, blood and blood products, needles and syringes and sexual activity. And then Hep D, contaminated needles and syringes and blood products, perinatal and unprotected sexual activity. And then Hep E is from contaminated water. We usually see this in underdeveloped countries that do not have the filtration or processing that, like here in the United States, we have for our water. The inflammatory process of hepatitis, whether caused by a virus, toxin, or other mechanism, damages specific cells and disrupts liver function. Cell mediated immune response damage hepatocytes and Kupffer cells, leading to hyperplasia, necrosis, and cellular regeneration. The flow of bile through bile calculi and into the biliary system can be impaired by the inflammatory process, leading to jaundice. When the inflammatory process is mild, like in Hep A, the liver parenchyma is not specifically damaged. However, the inflammatory process associated with Hep B and C can lead to severe liver damage. The metabolism of the metabolism of nutrients, drugs, alcohol, and toxins, and the process of bile elimination are disrupted by the inflammation. Some of the systemic effects that we can have are the formation of the circulating immune complexes, activation of that complement system, and then we'll see some different clinical manifestations such as rash, the angioedema, fever, malaise, abnormal proteins in the blood, glomerular nephritis, vascular cystitis, and other organ involvement. In the acute phase of liver injury, a large number of liver cells become damaged. When this happens, the liver cannot perform its normal jobs. This affects important functions like making bile for digestion, keeping blood sugar stable, and helping the blood to clot, and making proteins that the body needs. Another major problem is detoxification. Normally, the liver removes harmful substances from the body, but when it's damaged, toxins like ammonia can build up and medications and hormones may not be broken down correctly. The good news is that liver cells are able to regenerate. If the cause of the injury is treated early and there are no complications, the liver can heal and return to normal. However, if the damage is severe or continues for too long, it may become permanent. This can lead to liver failure, which can be life threatening. In the chronic phase, liver damage happens slowly over time. It can be silent at first, meaning a person may not notice any symptoms until the damage becomes severe. The liver cells continue to be destroyed little by little. As the body tries to heal this ongoing injury, scar tissue forms. This scar tissue interrupts normal blood flow and prevents the liver from working properly. Over time, the buildup of fibrous can progress to cirrhosis, a condition where the liver becomes stiff and permanently damaged. If cirrhosis continues to worsen, the liver may not be able to perform its essential functions, eventually leading to liver failure. When discussing viral hepatitis, we classify the clinical manifestations into two broad categories: acute hepatitis and chronic hepatitis. Let's begin by focusing on acute hepatitis. It is important to recognize that many patients with acute hepatitis have no symptoms at all. They may not even know that they're infected. For others, symptoms can vary widely and may resemble a flu like illness. Common complaints include anorexia, nausea, vomiting, and lethargy. Patients may experience diarrhea or constipation, malaise, fatigue, muscle or joint pain, and sometimes a skin rash. Discomfort in the upper right quadrant is also frequent because of liver inflammation. The acute phase of viral hepatitis typically lasts 1 to 6 months, depending on the specific viral type. During this time, patients may report a decreased sense of smell and that food tastes unpleasant. Smokers might suddenly find cigarettes distasteful. On physical exam, you often observe an enlarged liver along with abdominal tenderness. They may have enlarged lymph nodes and occasionally an enlarged spleen. This acute stage is crucial because it represents the period of maximal infectivity, meaning the patient can easily transmit the disease to others. A notable clinical finding during this phase is jaundice. This occurs when bilirubin metabolism is disrupted or when bile flow is obstructed within the liver or biliary ducts. As bilirubin accumulates in the bloodstream, it can lead to dark urine as the kidneys excrete excess bilirubin. Clay colored stools can happen because that bilirubin can't reach the intestines, and sometimes patients have an intense itching caused by bile salts depositing under the skin. This itching can be extremely uncomfortable and distressing for the patient. Overall, while some patients may recover without ever realizing they were infected, others experience a wide range of symptoms that reflect liver inflammation and impaired bile processing during the acute phase of viral hepatitis. In the convalescent phase, the patient is beginning to recover from liver inflammation. This stage can last several weeks to a few months, with an average duration of about 2 to 4 months. Patients commonly continue to experience fatigue and a general feeling of not feeling well. That's what we call malaise. During this time, the liver may still be enlarged, a condition known as hepaticomegaly. If the spleen was also enlarged earlier in the disease, that swelling typically improves during this phase as well. Most individuals recover fully, and the overall mortality rate is low, only about 1%. However, the risk is higher in older adults and those with significant medical conditions or comorbidities. Even though recovery is underway, complications are still possible. These include acute liver failure, chronic hepatitis, cirrhosis, portal hypertension, and even liver cancer if long-term damage continues. Acute liver failure is the most serious complication and has a poor prognosis. It can lead to confusion or coma from encephalopathy, problems with blood clotting like DIC, infection, kidney issues, low blood sugar, fluid buildup in the abdomen, trouble breathing, and dangerously low blood pressure. In these cases, a liver transplant is usually the only life saving treatment. Chronic hepatitis B is more likely to develop when someone is infected as a baby or during childhood. Some people may not show symptoms for many years, even though the virus is still damaging the liver. About 15 to 40% of people with chronic Hep B can develop serious complications like cirrhosis, liver failure, or liver cancer. Hep C is even more likely than Hep B to become a chronic infection. Without treatment, many people with chronic Hep C may go on to develop long term liver disease, including cirrhosis, portal hypertension, and liver cancer. For some patients, having both hepatitis and HIV can make the disease progress faster or change the way treatment needs to be managed. When the liver is damaged, several body systems can be affected. One common problem is anemia, which means the body doesn't have enough healthy red blood cells. This can make a person feel tired or short of breath. The liver also helps with blood clotting, so there may be bleeding or bruising more easily. We may also see changes in the skin and blood vessels. Spider angiomas look like small, red, spider shaped blood vessels on the skin. Palmar erythema is when the palms of the hands become red. Both are caused by changes in blood flow and hormones from liver damage. Men with liver disease may develop enlargement of breast tissue. This happens because the liver can't break down hormones normally. The spleen, liver, or lymph nodes and the neck may become enlarged because the blood flow in the body is disrupted and the immune system is working harder. If the liver damage becomes severe, toxins can build up in the brain and cause hepatic encephalopathy. This can lead to confusion, behavior changes, or even a coma, and it can be life threatening. Another serious side effect is ascites, which is a buildup of fluid in the abdomen. This is especially common in long term chronic liver disease. So, in your Lewis textbook on page 1140, table 48.5 goes over many of the diagnostics that we use. So, you might want to review that. The only definitive way to distinguish among the types of viral hepatitis is by testing the patient's blood for specific antigen or antibody. A liver biopsy is done in acute hepatitis if the diagnosis is in doubt. In chronic hepatitis, a liver biopsy allows for examination of liver cells and determination of the degree of inflammation. Non-invasive assessments like ultrasound elastography, which is a fibroscan, is able to determine the degree of the fibrous liver. And fibrotest, they are biomarkers that we use and that results of serum tests to assess the extent of the hepatic fibrosis. There is no specific treatment for acute viral hepatitis, and many of these patients are managed at home. We're looking to make sure they have adequate nutrition and rest so that they can repair and regenerate the liver. We're going to explain to them, the patients, that rest reduces that metabolic demand on the liver and promotes that ability for it to regenerate and repair. We're going to tell patients to avoid alcohol. And if they have one that has been transmitted due to unprotected sex, maybe IV drug usage, we're going to notify those contacts for testing and prophylaxis medication. And chronic hepatitis treatment, that may include, many members of the interdisciplinary team. We might have a patient, a physician that specializes in the hepatic system, maybe an infectious disease specialist, the pharmacist, a dietitian. We might need to have mental health or substance abuse specialists that get involved as well, especially if you have somebody that it's because of a history of drug usage or alcohol usage. Again, in your Lewis textbook on page 1142, table 48.7, you might want to review that. Again, it is the over drug therapy. So acute hepatitis, no drug therapies for Hep A. Hep B, only indicated with severe hepatitis and liver failure. Hep C, patients may choose to be monitored or they may choose treatment with one of the direct acting antivirals. Those are called DAAs. Supportive drug therapy may include antihistamines and antiemetics. Chronic Hep B drug therapy focuses on decreasing Hep B viral load and liver enzymes. Prevention of cirrhosis, portal hypertension, liver failure, and liver cancer. Drugs do not eradicate but suppress that viral replication. First line medications that we use are nucleosides, um, nucleotides, and sometimes interferons. For chronic hep C, treatment is patient specific and based on genotype of the hep C, severity of the liver disease, and other health problems. The goal is to eradicate the virus and prevent any hep C related complications that can occur. We use the DAAs, which block that replication of the virus, and the drug regimen is usually 12 weeks. Greater than 95% of the patients complete DAA treatment are cured. No special diet is part of the treatment of viral hepatitis. We want to emphasize a well balanced diet that the patient can tolerate. During acute viral hepatitis, adequate calories are important because the patient usually loses weight. If the patient does not tolerate fat content because of decreased bile production, it should be reduced. The patient may receive vitamin supplements, particularly B complex and vitamin K. The patient may, if anorexia, nausea, and vomiting are severe, we may give IV glucose solutions or supplements with enteral nutrition, and then fluid and electrolyte balance must also be maintained. Some of our nursing implementation, viral hepatitis is a public health problem, and prevention and control of the disease is what we're looking for. This can be in the form of doing a lot of community talks, going to the populations greater at risk, and providing additional education. For Hep A, it's more common among outbreaks. Hygiene and infection control, clean food and water. Vaccination is the best prevention, and we can give a vaccine, an IG, also used for prevention post exposure. Some of this with Hep A, of course, it would be maybe going into the restaurants and the people that are working there and explaining how it's important that they hand hygiene after they use the bathroom so that you're not um, You don't have a Hep A problem. Hep B, identify those at risk, screen and vaccinate those infected. For many of you, you've gone through those series of 3 IM injections and the deltoid. I know for my children, that was something that was a part of the infant um, regular immunizations that occurred. Um, but you all did it coming into nursing school as well, that you had to get the series of 3 if you did not have the antibodies for it. Post exposure prophylaxis, we can give the Hep B vaccine series and a Hep B IG. For Hep C, there's no current vaccine. We want to identify those at risk and teach those risk reduction. Screen blood organs and tissue donors. Infection control precautions modify high risk behaviors. And the CDC recommends universal screening for those born between 1945 and 65. These are our baby boomers. And part of the reason is because the way that we screen blood now really wasn't in place back then. And so there were people that ended up with Hep C because of transfusions and blood products. And then we're going to also monitor post exposure. All right, so now we're going to talk a little bit about pancreatitis. The normal function of the pancreas involves the release of pancreatic enzymes in the duodenum to assist in the digestion of proteins, starches, and fatty acids. Food entering the small intestine stimulates release of the pancreatic enzymes. However, in pancreatitis, the pancreatic enzymes are activated early and digest the pancreas and pancreatitis. So when it digests that pancreas and surrounds the tissues, a process that we call autodigestion. Pancreatitis can be acute or chronic. There are between 13 and 45 newly diagnosed cases of acute pancreatitis every year, and approximately 5 to 12 cases of chronic pancreatitis occur each year. Acute pancreatitis is an inflammatory disorder that involves self destruction of the pancreas by its own enzymes through that autodigestion. It is most common in middle aged adults. Gallstones and alcoholism account for the majority of the cases of acute pancreatitis in the U.S. Some patients with acute pancreatitis recover completely. Others experience reoccurring attacks, and still others develop chronic pancreatitis. The mortality and symptoms depend on the severity and type of pancreatitis, as well as the patient's age and general health. Although the exact cause of acute pancreatitis is not known, the gallstones may activate pancreatic enzymes within the pancreas, leading to that autodigestion, inflammation, edema, and/or necrosis. Other factors associated with acute pancreatitis include tissue ischemia, trauma or surgery, pancreatic tumors, third trimester pregnancy, infectious agents, elevated calcium levels, and hyperlipidemia. Some medications have been linked with this disorder, including thiazide diuretics, estrogen, steroids, and NSAIDs. Acute pancreatitis develops suddenly, typically with an abrupt onset of continuous, severe epigastric and abdominal pain. This pain commonly radiates to the back and is relieved somewhat by sitting up and leaning forward. The pain often is initiated by a fatty meal or excessive alcohol intake. Other manifestations include nausea and vomiting, abdominal distension and a rigid abdomen, decreased bowel sounds, tachycardia, hypotension, elevated temperature, and cold, clammy skin. Within 24 hours, mild jaundice may appear. Retroperitoneal bleeding may occur 3 to 6 days after the onset of acute pancreatitis. Signs of bleeding include bruising in the flanks or around the umbilicus. The pictures on the screen kind of give you an idea of the the flank and the umbilicus area that it gets the bruising and what that looks like. So the flank is called Gray Turner sign, and Cullen's sign is when it's around the belly button area. Shock from hemorrhage into the pancreas, toxemia from activated pancreatic enzymes, and hypovolemia from massive fluid shifts into the retroperitoneal space. Systematic complications of acute pancreatitis include intravascular volume depletion with shock, acute tubular necrosis and renal failure, and acute respiratory distress syndrome, or ARDS. Hypovolemic shock and acute renal failure usually develop within 24 hours after the onset. Manifestations of ARDS may be seen 3 to 7 days after the onset. Localized complications include pancreatic necrosis, abscesses, pseudocysts, and pancreatic ascites. The necrosis causes an inflammatory mass that may be infected. It may lead to shock and multiple organ failure. Pancreatic pseudocysts, encapsulated collections of fluid, may develop both within the pancreas itself and in the abdominal cavity. They may impinge on other structures or may rupture, causing generalized peritonitis. Rupture of these pseudocysts or of the pancreatic duct can lead to pancreatic ascites. An infected pancreatic pseudocyst becomes a pancreatic abscess. The ascites is signaled by gradual increasing of abdominal girth and persistent elevation of the serum amylase level without abdominal pain. So some of the diagnostic tests, we're going to look at the serum amylase and lipase, um, blood levels. We can do an ultrasound, which it can identify gallstones, maybe a pancreatic mass, or a pseudocyst. The endoscopic ultrasonography can detect changes indicative of chronic pancreatitis in the pancreatic duct. CT scan with contrast to identify pancreatic enlargement, ductal calcifications, fluid collections in or around the pancreas, and perfusion deficits in area of necrosis. An ERCP is used to diagnose chronic hepatitis and to differentiate inflammation and fibrous from maybe like a carcinoma. Some of the interprofessional care, we're going to prevent or treat infections, relieve any pain that the patient might have, prevent and alleviate shock, the reduction of the pancreatic secretions. We're going to correct any fluid and electrolyte imbalances, remove any precipitating causes. Of course, we're going to treat shock if it's present. We place the patient on NPO. We usually insert an NG tube and place it to suction. And then we'll have enteral nutrition to support feedings. So a couple of the surgical procedures that we can do, of course, we can drain the drainage of a pseudocyst if it is indeed present. But the surgical therapy, we usually do like a stat ERCP, and depending upon what that evaluation looks like, they may follow that up with the laparoscopic removal of the gallbladder. Textbook on page 1162, table 48.20. You might want to review that. It goes over drug treatment and nutritional therapy. The treatment of acute pancreatitis is largely supportive. We use opioid analgesics such as morphine sulfate or Dilaudid may be used to control pain. Prophylactic antibiotics are prescribed for patients with severe or if there's any necrotic parts of the pancreatitis to prevent infection. Antacids help to neutralize gastric hydrochloric acid secretion. Antispasmodics help to relax smooth muscle, and we also give supplemental O2 therapy so that it can be used to maintain an O2 saturation of or above 95%. PPIs help to decrease acid secretions. Oral foods and fluids generally are withheld during acute episodes of pancreatitis to reduce any of those pancreatic secretions and allow the organ to rest. An NG tube may be inserted and connected to suction. Administer IV fluids to maintain vascular volume and initiate total parenteral nutrition or TPN. Begin oral food and fluids once the serum amylase levels have returned to normal, bowel sounds are present, and pain disappears. When food is allowed, start with small, frequent foods or feedings. And you're going to have an order for like a low fat diet, high in carbohydrates, and it will strictly prohibit any alcohol intake. So some of the things you're going to do is monitor those hemodynamics status of the patient. So I'm going to be looking at vital signs, going to continue to do my assessment, especially assessing the lungs to make sure there is no fluid. So you would hear crackles in the lungs. We're going to look at fluid and electrolyte balance, and we're going to um, give whatever we need to in order to get that balance back out. We're going to monitor the INOs, what their intake and output is, monitor for hypocalcemia, and medicate for pain. So the opioids like the morphine sulfate or the Dilaudid. And then if a patient does indeed have an NG tube inserted, we need to make sure that we're monitoring and documenting the output of the NG tube. Chronic pancreatitis is characterized by chronic inflammation, fibrousness, and gradual destruction of the functional tissue of the pancreas. Alcoholism is the primary risk factor for chronic hepatitis in the US, and malnutrition is a major worldwide risk factor. About 10 to 20% of cases of chronic pancreatitis are idiopathic with no identified cause. A genetic mutation on a gene associated with cystic fibrosis may play a role in these cases. In chronic pancreatitis related to alcoholism, pancreatic secretions have an increased concentration of insoluble proteins. These proteins calcify, forming plugs that block pancreatic ducts and the flow of the juices. This blockage leads to inflammation and fibrous of the pancreatic tissue. In other cases, a stricture or stone may block the outflow, causing chronic obstructive pancreatitis. Recurrent episodes of inflammation eventually lead to the fibrotic changes in the periosteum of the pancreas with loss of exocrine function. This leads to malabsorption from pancreatic insufficiency. If endocrine function is disrupted as well, clinical diabetes mellitus may develop. Chronic pancreatitis typically causes recurrent episodes of epigastric and upper abdominal pain that radiates to the back. This pain may last for days to weeks. As the disease progresses, the intervals between episodes of pain become shorter. Other manifestations include anorexia, nausea, and vomiting, weight loss, flatulence, constipation, and they get this fatty, frothy, foul smelling stools that are caused by decrease in pancreatic enzyme secretion. Complications of chronic pancreatitis include malabsorption, malnutrition, and possible peptic ulcer disease. A pancreatic pseudocyst or abscess may form, or a stricture of the common bile duct may develop. Diabetes may develop, and there is an increased risk of pancreatic cancer. Opioid addiction related to frequent severe pain episodes is also common. Diagnostics are based on the signs and symptoms. Of course, we're going to monitor the blood and look at the amylase and lipase. We do the same ERCP, CT scan, or ultrasound. One difference is that we're looking at the stools for any of that fat content, and we can do a glucose intolerance, and diabetes, because of that, diabetes may develop. And then we're also going to look at fat soluble deficiencies because of it not being absorbed. Patients with chronic pancreatitis may also require analgesics, but must be closely monitored to prevent drug dependence. Pancreatic enzyme supplements are given to manage abdominal pain and reduce that fat in their stool. Patients with chronic pancreatitis may need to remain on pancreatic enzyme supplements for life. H2 blockers such as Tagamet and Zantac and PPIs such as Prilosec may be given to neutralize or decrease those gastric secretions.